Good morning. Welcome to this interesting session about novel therapeutic approaches for life-threatening arrhythmias. We are sharing the table, Dr. Enrique, Rodríguez from São Paulo, Barcelona, and me, Nicasio Pérez Castellanos from Hospital Clínico San Carlos in Madrid. And we have the opportunity and the pleasure to have four excellent
this message.
Excellent presenters to cover four different topics in this kind of scenario, life-threatening arrhythmia. We have 15 minutes for each presentation, and at the end we will have a common discussion between everybody.
You are on air.
To the realization, we have some noise in here. I don't know if it is any open microphone. Okay, we will have to give the opportunity to talk about identification of the functional and structural substrate in Brugada syndrome to Dr. Jiménez Jaimez, Juan from Virgen de las Nieves, Granada. Juan, thank you.
Okay. Hello, thank you very much to the organizing committee of the Congress. It's a pleasure being here with this fantastic roundtable. And the topic I have to talk is identification of the functional and structural substrate in Brugada syndrome. I have no conflict of interest. Well, Brugada syndrome is a complex, challenging disease where we have multiple clinical scenarios. Since we can see people dying suddenly at a very early age in life, people that remain completely asymptomatic until late in life, and people with symptoms that are announcing a possible sudden cardiac death. This is a complex disease because it has incomplete penetrance, variable expression, and the genetic underground is not completely fully understood. Most of the mutations are in the SCN5A sodium channel, which encodes for a sodium channel like this family that we have in Granada, in our center. And as you can see here, we have all the spectrum of the clinical manifestations of the disease. And so this is something that we don't fully understand, how a patient can die suddenly with exactly the same mutation as a patient that is remaining completely asymptomatic. Why? What's the reason? This is something is unknown, as the same as in other genetic inherited conditions, cardiovascular conditions. Sorry. Oh. And these are unresolved questions in Brugada syndrome. Is this a pure ion channelopathy, or there is adding some form of structural disease underlying? Sometimes you can identify and sometimes not. Which is the genetical background, because we know just for 1/4 of the cases that is sodium channel. What happens with the remaining cases? What about the variable phenotypical expression? Why are people dying suddenly? What's the meaning of that delayed potential and fragmented potential in the right ventricular outflow tract? What's the meaning of that? Is that a trigger? Is that a driver? Is that something we should fight against? What's the role of medical therapy and ablation of these late potentials? And what are the challenges of the risk stratification? I'll try to elucidate a little bit in the connection between functional affection of the sodium current going into structural abnormalities. Translating these changes into potentials we can see and targets for treatment. This is something that very, very early, just 5 years after the description of the syndrome, the Brugada brothers arose in this chapter about cardiac arrhythmias, trying to elucidate if there are structural abnormalities beyond the ion channelopathy, and the conclusion was that it was a pure electrical disease. This is something that after 20 years has changed now, up to now, as I will try to show you later. What is the essential of the initial pathophysiology of the Brugada syndrome? How does the Brugada syndrome start causing these alterations in the currents and after that in the myocardium? Well, there are two theories, and I must say I'm not sure which one is the correct, or if it's a mix of both. One theory is the decreased depolarization current. You have a sodium. This is mainly applicable to patients with sodium channel mutations. Depolarization currents that are decreased, and this leads to a reduction in the conduction reserve, mainly at the epicardium of the right ventricular flow tract, and this leads to circus type or spiral wave reentries. The other theory, perhaps more accepted in the past, is the increased currents, the E-subtor current in the phase 1, like a fast repolarization current that is increased, and there is a disbalance between the repolarization in the endocardium and the epicardium. So this causes a gradient of the repolarization leading to phase 2 reentry arrhythmias. Well, these are two theories that up to now, the delayed action potential and the gradient, perhaps they are coexisting, but now the most accepted is the depolarization theory. The conduction reserve theory perhaps is the most accepted nowadays, and I try to show you some functional and ultrastructural studies showing this interaction between the sodium channel and the connexome and the gap junctions. What's happening after a mutation in the DNA in the sodium channel? Of course, this is mainly referring to patients with sodium channel mutation, because 75% of Brugada patients do not show any mutation. So, sodium channel mutation finally end up affecting the tissue, affecting the gap junctions, affecting the connexome, and this causes fibrosis. This, with the electrical discontinuity, with the altered depolarization and perhaps the repolarization, shows finally the final picture of the Brugada syndrome in the right ventricular outflow tract, that is where this sodium channel and this connexome mainly are expressed. And under some acute modulators, you can see the phenotype and suffer from ventricular arrhythmias. And why do I say this, that the sodium channel mutation finally end up affecting the gap junction? There are some studies, some of them, perhaps this is the first paper that started showing this connection, that in the places, in the right ventricular outflow tract epicardium, the places where there is late potential, fragmented, abnormal potentials, like the one you see here in the image, is clearly correlated in studies with advanced cardiac imaging and sample of biopsy with fingerprints, fibrous tissue going inside the myocardium. And this is the place where correlates very well, seeing this tag, with the places with the abnormal potential. We can see what the places, this is a very, very interesting paper, places where there were no late potential, there were no fibrosis. So we started to see a correlation between the functional and the structural. 3 years later, this group, led by the Brugada brothers, showed us that when we have a clear patient with Brugada type 1 phenotype in vivo, in the patient with unipolar and bipolar maps, we were able, the unipolar maps, to see in subclinical cases an area of reduced voltage in the right ventricular flow tract epicardium, mainly in the free wall, in some cases without histological substrate, and in other with clear fibrosis in areas in patients perhaps with a more advanced status. They saw not only fibrosis, they also saw inflammation. So inflammation, fibrosis are present in the places where these patients have the late potential and developed, showing in the basal ECG as the type 1 Brugada syndrome. And this is the last paper, this is very recent, 2 weeks ago, by the group from Burdeos, from Heiseguerre. They have done a very, very complete approach to see an in vivo, ex vivo, heart of a donor, a boy that suddenly died at the age of 15 and was a carrier of a pathogenic mutation in the SCN5A. This was shared with his mother that showed a positive Achmalin test. So this seems to be a sudden death due to Brugada syndrome, and they explanted the heart, and they compared confocal microscopy, histological magnetic resonance, and Western blot to see how the correlation between the abnormal potentials and the histological and late potential and the connexome was present. They compared with 9 normal control heart died from other causes, and they were able to show that, here it is, the expression of the sodium channel in these areas was very, very low compared to control hearts, as well as the connexin 43. The connexin 43 is a very, very important protein in the electromechanical continuity in the desmosome and the gap junctions. So for the first time, we saw in an ex vivo heart the relation, the close relationship between these areas of low voltage, this is with confocal, reduced conduction velocity at that areas, mainly at the epicardium, and when pacing at higher frequencies and under an activator of the asymptote current, even showing some degree of action potential alternance, leading to, that finally would lead to a ventricular arrhythmia. So this is more evidence showing that there is a correlation between electricity and histological fibrosis in Brugada syndrome. Until this very, very recent paper, even they try or they suggest a new definition for the Brugada syndrome, including under the same umbrella, idiopathic ventricular fibrillation, the J-wave syndromes, and the Brugada syndrome, and this term, which is called subepicardial cardiomyopathy, due to they have been able to demonstrate that this impaired, after the sodium channel mutation, this impaired current, sodium current, is able to cause some electromechanical alterations during the follow-up time, as you can see here in the resonance imaging. And they suggest this scheme for this disease, subepicardial cardiomyopathy. I think we have much more, we need much more evidence to apply this term, where in Brugada, early repolarization and ABF finally develop an arrhythmogenic cardiomyopathy phenotype with late potential and very, very delayed fibrosis in the subepicardia. So this could be a target. This could be a target because here in the epicardium, you can have the triggers or the drivers of ventricular fibrillation, which is the event that we want to avoid in Brugada syndrome. This is something that the group from Pamplona and Josep Brugada have been telling us from the last 5 years with isolated cases, small series. You see that they were able to show us very beautiful maps where they ablated a little bit, as you see here, to eliminate, to disappear the type 1 pattern. This is something that should be good, but you are leaving some scar here, a scar. What's the meaning of that? Now we have, very, very recently, the results of the Bravo study, which have been a long follow-up of patients with ablation of the right ventricular flow trap. And you can see here the graph that there is a dramatic reduction in appropriate therapies for BF. This is after the ablation, and this was before the ablation. This is not randomized, of course, but the sample size is sufficient, is enough. And I think the prospective follow-up is convincing for us. This is the most important thing to achieve this goal is to eliminate the type 1 pattern. As you see the difference here, a significant difference. This is so important results that Viskin, for example, did in the first works in 2018, some editorial saying, don't go burning my heart. He criticized the ablation because there were no evidence. And now the same author is doing an editorial for this Bravo study, which is changing the attitude, is suggesting this could be a new tool in Brugada syndrome after the demonstration of this correlation between fibrosis and late potential. So this could be a new tool. Of course, up to now, nowadays, this is a strategy that we should use for refractory arrhythmias patients, not for all patients, and overall not for asymptomatic patients up to now. Where were the drivers? Where were the abnormal late potentials areas? Mostly, all the patients have them at the right ventricular flow tract epicardium, some of them at the Purkinje system in the right ventricle, and very few in the left ventricle. You can see here how, for example, in the right ventricle, you see an area of late potential that after the ablation is completely disappeared. And they were able, this is the group from Burdeos, to map and to see how the BF is starting, but also maintaining in the first, this is a very recent paper from the same group, where they are able in Brugada syndrome and in other cardiomyopathies to map, to try to see this first phase of the BF that is somehow organized. The drivers are located near these structural areas of late potentials. And they suggest that ablation, this area that in Brugada syndrome are located, as we know now, in the right ventricular flow tract epicardium, and the outcome, as you have seen in the Bravo studies, certainly very good. And the last thing is the incomplete penetrance. Why patients suffering from Brugada syndrome show different sides of the same coin. This is a family from our group that we were able to publish with Dr. Del Pont here in the round table, that they showed different sides of this same coin of a truncating variant in the SCN5A. One patient developed BF started with a trigger that we were able, in 2009, 17 years ago, to ablate here in the right ventricular septum. No shocks after 17 years when we eliminated the triggers. You see here, a very, very early potential in the extrasystole that was initiating the BF. But she did not show Brugada pattern at any moment. Not on that moment, not in the follow-up. But when we did the functional expression, we saw that there was a drastic reduction in the sodium current and the traffic into the membrane. This is something that Eva can explain much better than me. But the surprise was that in the family, there was some patients, some carriers showing the Brugada pattern. Why is this? What's the explanation for this? Why is a patient suffering BF but not Brugada? Is this the subepicardial cardiomyopathy? We don't know, but I'm sure that this family that we did not study with the structural imaging, they show structural abnormalities in the right ventricular flow tract. And perhaps this is unpublished material from the group from Santiago de Compostela. Perhaps the explanation is the transcriptome, the microRNAs, sorry for saying in Spanish, the microRNAs that are overexpressed, some of them very important, that play a very important role in the electromechanical continuity and in the gap junction between the cardiomyocytes, are overexpressed in patients with very clear phenotype and underexpressed in patients with no phenotype. So in conclusion, in Brugada syndrome, I think there is now evidence that this initial channelopathy has a very important conduction reserve and impairment that is leading to a mechanical substrate, so gap junction and connexome affection. Well, this subepicardial cardiomyopathy is a very interesting way to follow, but I think it's very, very early to say this. And this substrate, delayed fragmented potential, mainly at the right ventricular flow tract, they may act as triggers or drivers, and they can be targeted by ablation. Now we have this very interesting long-term follow-up study, Bravo. So the ablation can reduce significantly the density of malignant arrhythmias and can correct the type 1 Brugada pattern. So I think our approach, this should be reserved for refractory ventricular arrhythmias patients, but perhaps in the future it can be open to all the spectrum of the patients. Thank you very much.
Thank you very much. Thank you.
Now, I'm going to present to Dr. David Filgueiras, that is one of my co-workers in the Hospital Clínico San Carlos. He's also an investigator at the CENIC in Madrid. And he will talk about novel imaging approaches to target and ablate infarct-related ventricular tachycardia. David, thank you.
Thank you for the invitation. It's a pleasure to be here. And I'm going to talk about this topic, about the role of imaging and how we can understand better the substrate when we go to ablate patients with ventricular tachycardia. These are my conflict of interest. It's not related to the topic of this talk, but still it's a conflict of interest. As an introduction, I would like to say that, of course, when we are in front of a patient with ventricular tachycardia, the first thing we would like to have is this kind of beautiful mapping that the patient can tolerate, and we can map carefully and then target the specific site where the protected isthmus may be. But this is difficult to find, and we already know that we sometimes will need to deal with other approaches, and some of them are related to electrophysiological data, and other approaches are related to imaging data. So we can find specific areas that may be related to the ventricular tachycardia. Still, we don't have the solution, the proper solution to say 100% that the tachycardia will be there. So the main limitations we have with electrophysiological approaches is that we still need an invasive procedure, and that invasive procedure will require time-consuming maneuvers and mapping to do that, and one approaches may take longer than others. So if we do imaging, in imaging we will have the problem mainly with MRI, that signal intensity cutoff values will vary from series and series, from one series to another series. And that's an important issue that we should keep in mind, especially when we work with imaging. And also the quality of the imaging may affect our outcome from the imaging. And also, there is no universal cutoff value that we can use from lab to lab and say this is what we need to use. So if you look fully at this graph, it will show you the main limitations we have. So you will see from different series cutoff values for signal intensity from MRI imaging with late enhancement that will give you values at 40% of the maximum signal intensity, but others will give you values of 50%, and your scar will change. Your outcome of scar will change from one value to another. In fact, if we define the scar at 60%, the dense scar at 60% of the maximum signal intensity, we will have much more dense scar. Theoretically, that dense scar will not conduct electrical activity, or we will assume that. But still, there are many limitations to know what is the proper range. And this range of signal intensity cutoff values may be appropriate at one signal intensity cutoff value for one patient, but for another patient may be different. So this is an important limitation, and some people is critical with this kind of processing from series to series. So in fact, it's not only that. When we use imaging as a guide to do our ablation, we also need to validate that with proper recognition and identification of the protected isthmus. And this is lacking in the literature at advanced levels. So I would like to show this novel data, and this is the first time I would like to comment this because for me it's important to share this data with you in this meeting, because this is the first time we show this data after almost 10 years of working on this series. So the data I'm going to show is very, very novel. So in this study, we aimed to develop and validate a novel systematic processing approach on late gadolinium enhancement, CMR images, to identify potential VT channels that include the protected isthmus sites associated with VT maintenance. This is difficult because first we need to know where the VT is located, which is a challenge by itself. This is the study design, and as you see here, the first thing we need to know is where the VT is located. So this requires, most of times, activation mapping, entrainment maneuvers, sometimes pace mapping, trying to localize the VT isthmus site. This is not possible in all patients undergoing VT ablation. The second thing, we didn't want to be biased to one single cutoff value, signal intensity cutoff value. So we swept many different signal intensity cutoff values to be objective, not just 40 and 60, 45, 65%, but we went all the way from the lowest reported cutoff value in the literature to the highest one. And this, we were dealing with different 15 signal intensity cutoff values for a single patient. So we can have all the possibilities about channels for one particular patient. Which is the proper one, we don't know. But if we select one signal cutoff value, we don't know either if that's the most appropriate for that particular patient. So after that, once we have the VT area, we can compare if the VT area where the protected isthmus may be located will correlate at least with one of the areas that we have identified as potential substrate for the VT. So this is difficult to do. The first step we did was in animals, and we performed more than 20 animals, but then only 8 of them were able to map where the VT was located. So this is the same problem we have in patients. The patients are not tolerated, so we cannot complete the mapping. In patients, more than 30 patients were included, and we were able to characterize 19 VT morphologies from those 70 patients. Also, the number of patients potentially candidates were higher. So the first thing we did was to process the imaging with this software, commercially available software with the ADAS VT software. And as you see here, this is a single example where you can see some potential channels within the scar, but this is just for one signal intensity cutoff value. So if we want to have all the picture, we will need to go through all signal intensity cutoff values potentially affecting this patient. So what we did was with the software, we were scanning from 33, 53 up to 47, 67% of the signal intensity cutoff value. And the additional problem is that you may have channels in the 10% of the myocardial wall thickness close to the endocardium. But you can also have channels in the 50% of the myocardial wall thickness in the layer. So what do you do with that? So this is an additional problem. What do I select the channel that is in the 20% and not the one that is in the 30%? So we computed all those channels, and later I will show you how we process this problem. So then, of course, we divided the channels that could be in the endocardium, in the half myocardium of the myocardial wall, and also the ones that could be in the epicardium, so we can use a kind of footprint of the channels in the endocardium and also a footprint of the channels in the epicardium if your patient could have a VT morphology that suggests the epicardial approach. So once we have all that information, we can do the following. So if we have some channels with this threshold, signal intensity threshold, for the 10% layer of the myocardial wall thickness, we can still have more channels. These are the red ones above the black ones that were coming from the previous threshold. So we are adding potential channels to our picture of the endocardial wall. And also, we will need to add the channels that are coming from other layers of the myocardium. So finally, we could have an entire picture for each layer, but also we will need the entire picture for the half myocardial of the myocardial wall thickness. So as you see here, we can project all that information of potential VT channels using all those signal intensity thresholds in the endocardium. So this is the real picture, objective picture of all potential VT channels for that particular patient. We can do the same also for the epicardium, so we can project the information because these patients were patients with ischemic cardiomyopathy, so it makes sense that the scar in the epicardium and potential VT channels in the epicardium will be much smaller amount than in the endocardium. So the next step we need is the information about the actual VT site, where the protected VT isthmus may be. And this is what we did in animals. This is a mapping, complete mapping of one animal with activation maps and also entrainment to demonstrate that the protected isthmus site is in this particular area. How we do define the area that we need to compare with the imaging that we obtained? So what we did was the following. So, of course, activation mapping may be complete or not. If we have more than 90% of the cycle length of the VT will be fully mapped. So what we did was, in cases where we have the earliest activation time with plus 20% of the tachycardia cycle length, and the latest activation time minus 30% of the tachycardia cycle length will give us an area where the protected isthmus site will be located. So this was how we localized the electrophysiological region of interest. Of course, once we have the imaging and we have the electrophysiological region of interest is the blue one, we can have the shared area between the two. And the shared area is the black one. So you have here that in this particular case, in this animal, you have some shared area between the blue and the red. The rest of the red didn't play any role in this particular tachycardia for this animal. So the overall results, and I would like to highlight all the collaboration from the lab to do these complex experiments in animals. So what we do was to characterize, this is a different case with the region of interest and the black area that was sharing with this, or was overlapped with this red area. So overall, we were able to induce on average, a couple of VTs per animal, and we were able to characterize in around 20% of them, 30% of them more than 2 VT morphologies, and in the majority of them, just 1 VT morphology. So as you see here, the overall results in animals show us that the areas where the potential VT corridors could be is much smaller than the total scar area, that is the black one here, the black dots. And the areas where the VT, the actual VT is located, is much smaller, of course, than the red area. So the VT is a small portion of all the potential VT channels we see on imaging. So in fact, how much of the, or what amount of the blue area could be in the red? Because some of the blue is not in the red, right? So around 30%, or 33%, if I recall exactly, is located within the red area. That area is related to the EP region of interest. And if we look carefully at those electrograms that share at overlapping between the blue and the red, most of those electrograms, in fact, supporting our analysis, are within the protected isthmus sites. So those electrograms that are sharing the blue and the red, and in black color, are located mainly in the area defined as protected isthmus sites. So those shared areas are important. If we move to patients, and I would like to give a great thank to the collaborators in 4 institutions, the clinic in Barcelona, Maastricht Hospital, La Paz Hospital with Dr. Merino and Dr. Peinado, and also Dr. Andreu also in the clinic. This is difficult to find these patients. Without their collaboration, this wouldn't be possible. And also, these images were done with 3-dimensional MRI sequences that we couldn't collaborate with other centers because most of centers perform 2-dimensional CMR sequences. So as you see here, this is one case from Barcelona, beautiful case, with one VT morphology and the shared area within the potential VT channels in this particular case. Similar to animals, we are very close to the pig model. I got a strike how similar we are with the infarction. So look at this. We were able to map in most of patients 20% just only VT morphology, and in a few of them, a couple of VT morphologies. So look at the data. It's very similar to the animal model. The red area is, in general, much smaller than the total scar, and the VT areas, of course, are smaller. In the patients, the shared area between the blue and the red was slightly higher than in the animals, 40%. And if you look at the electrograms in the shared area, you see that, of course, most of the electrograms were within the protected isthmus site. So what happened if we do ablate? Of course, we didn't do a prospective study here to know whether the ablation could be enough. We will need a randomized study to do that. But this is a case from the Hospital Clínico San Carlos. And as you see here, we ablate this particular area where the VT was located, and it terminates in this particular spot. And we continue the ablation in this area. The region of interest for the VT is the blue border that you see in there. We didn't ablate this particular area that was identified on the imaging. It was not related to that VT morphology. So how much we and our collaborators ablate? Most of us ablate between a small percentage and 25% of the total scar area. So we did not need to ablate all the scar area identify as a potential VT channels to terminate these VTs. So this doesn't mean that if we need to do just pure imaging approach, we can ablate, of course, everything we need from the red area, but if you know where the VT is, of course, you don't need to ablate everything. So 15 signal intensity thresholds is a lot. So the next question we had is, can we decrease the number of signal intensity thresholds to have less amount of red scar potentially related to channels? This is what we did in this particular analysis. As you see here, the most common signal intensity thresholds related to the actual VT area were these in patients. And if we decrease from 15 signal intensity thresholds to 7 signal intensity thresholds, we will decrease the area of the potential VT channels, but we will not affect at the same amount the overlapping area. So this will be a good approach. We will not miss, basically, in this series, any VT region of interest. So this is important. However, this is one example. So you see, in this case, the VT region of interest is this blue one, and the potential VT corridors is the red one. If we decrease from 15 to 17, we still had that. So this is quite amazing in this case. That's why I'm showing it. And of course, if we need to perform just pure imaging-based approach, this will not require a very long ablation time. So, however, if we go from 7 to 5 signal intensity thresholds, the problem is that we will miss the area that is important for the VT. And if we further decrease to the 3 most relevant ones within our series, we still miss the most important area. So if you are completely objective, you will know what is the best signal intensity threshold. What we propose here is to basically stick on an objective approach to process the imaging. Otherwise, you are biased, and there is a problem with that. So what we have here is the main results. Look at the graphics. They are very similar between pigs and patients. And what you see here is the total scar. The percentage of the total scar that will lead to potential VT corridors is 38% in pigs, is 38% in patients. That's amazing. So if we look at how much of the EP-defined area is overlapping with the red, is 33% in animals, is 40% in patients, and most of the electrograms, both in pigs and in patients, are related to the protected isthmus site. So both of the electrograms that share that region. So if we decrease the thresholds, this is the main message I want you to keep in mind. So if we decrease the number of thresholds from 15 to 7, we will not affect the shade area, just 5%, but we will decrease this 38% by 20%. So we will still have chances to effectively treat the VT without missing the important point. So I would like to acknowledge all the collaborators in the hospital clinic. Of course, my colleagues help us a lot, and also the lab in CENIC and my collaborators in CENIC. So thank you very much for your attention.
Thank you very much for this interesting lecture, Dr. Filgueira. And for the next presentation, from the next presenter, we will connect to Zoom. Dr. Cluitmans is going to talk from the Maastricht University Medical Center in the Netherlands. Good morning, Mr. Cluitmans.
Good morning.
Good morning, and welcome to Ritmo meeting.
Thank you. Thanks for inviting me. I'm very excited to be talking here. I will talk about electrophysiological basis for specific therapeutic targets for VF. Let me start with my disclosures. I'm working at Maastricht University Medical Center, but also at Philips Research, and I'm writing for a newsletter that I recently started. When we talk about arrhythmia initiation, and typically the start of a re-entry, we know that the triangle of Kumel is a very useful way to think about this. It discusses the need for a trigger and a substrate and the effect that modulators may have. Without any trigger or substrate, there's typically no arrhythmia, which is one of the two. We also don't see an arrhythmia. And it's only when we see both a trigger and a substrate in the same condition that we see unidirectional block that may lead to re-entry. This classical way of reasoning about trigger-substrate interaction has been very useful. And we can apply it to structural and functional substrates. In particular for structural substrates like fibrosis and channels, such as we just discussed, we know that the substrate is, we understand the substrate fairly well. We know that the zigzag and slowed conduction in these channels is a very important substrate. On the other hand, for non-structural disease, so functional substrates, it's more challenging. We know that abnormalities in conduction and repolarization play a role in some of these functional diseases. And sometimes we don't know, but we don't see any functional abnormalities either. In those conditions, the trigger-substrate interaction is less well understood because we don't have a good clue on what the functional substrate could be. And I will expand on that a little bit before I come back also to structural substrate. So let me first focus on functional substrates, and in particular on unexplained sudden cardiac arrests, otherwise called idiopathic ventricular fibrillation. And you can see an example from Maastricht, where this individual, after a premature short coupled beat, got polymorphic VT and later VF. This individual was, of course, clinically tested. We did all the diagnostics necessary in this individual, but none of these tests came back with a clear cause for their VF. That means that per exclusionem, because we crossed away all the other causes, we arrive at the diagnosis of idiopathic ventricular fibrillation, or unexplained sudden cardiac arrest. And the challenge with unexplained sudden cardiac arrest is, of course, that it is sudden and unexplained, which makes it very difficult to study. The clinical problem then is that it's challenging for these patients to risk stratify what is their risk for a repeat VF, but also for their family members. We do not know how to risk stratify their family members. And since we do not know what's happening, we can also not really look for targets or therapy, and we are limited to symptomatic treatment. This is all rooted in the basic science problem that we have a lack of understanding what the arrhythmia mechanisms are that lead to idiopathic ventricular fibrillation. We believed that the repolarization could play an important role here, in such a way that we think that there are repolarization abnormalities that we cannot detect with normal clinical tools, but that may form the substrate in these patients. Again, in this specific individual, we performed non-invasive mapping, non-invasive electrocardiographic imaging, not just of their activation pattern, but also of their recovery pattern. And you can see the repolarization map here. On the right ventricle, we see a region of very early versus very late repolarization. You can see the red region, which is very early, versus the blue region, which is very late. And the electrograms from that region indeed show that the local T wave, the local repolarization wave, has an opposite polarity. This sparked the hypothesis that regions of early repolarization next to regions of late repolarization create a repolarization dispersion that may be critical for the induction of reentry, but cannot be detected with clinical tools like the 12-lead electrocardiogram. And I will show you that during the course of our studies, we were able to extend this triangle of Comel into something that we've now called the circle of reentry that dives deeper into these phenomena. We first studied this in explanted hearts. I did this when I visited Bordeaux for a year at the Lyric Institute, where they are able to explant human and pig hearts and then infuse drugs in different regions of the heart. So we had a penicillin infusion in this region and then the fetolite infusion in the rest of the region. These drugs have opposite effects on repolarization, which means that if we record repolarization with an electrode soak that's wrapped around the heart, we can see that there will be an early repolarizing region and a late repolarizing region. And you can see that in these recordings of an explanted heart, where the central region here becomes much earlier, much more deep red, and the lateral regions become much more late, much bluer, due to the infusion of the fetolite and penicillin drugs. This means we can artificially create these repolarization time gradients, these dispersion of repolarization. What we then did is, on top of this normal activation, so we did atrial stimulation to get a normal ventricular activation. Obviously, due to the drugs, we see an abnormal repolarization, and then provide an extra stimulus, an S2 stimulus on the ventricles. We saw that you can induce reentry. In this example, the reentry blocks here, which is exactly at the repolarization time gradient, and then travels around that gradient until the late repolarizing region is recovered and can be activated again, resulting in this circle reentry. We notice that doing this and getting reentry is much easier if we infuse more of these drugs. In other words, when we create steeper repolarization dispersion, it's easier to get reentry. We also notice that this is particularly so for short-coupled stimuli, which of course is known already. And this starts to build this circle of reentry. The first element is an early premature beat, so this S2 stimulus needs to be early enough. The second element is that we saw that we really need these repolarization time gradients to get unidirectional block. So reentry needs both an early trigger and these repolarization time gradients. What we then studied is to give this stimulus at different locations. And what you can see here is that when we infuse those drugs, the early repolarizing region always yielded an S2 stimulus with reentry, whereas the late repolarizing region never gave any reentry. In other words, the stimulus needs to come from the early repolarizing region to be able to start a reentry. We now have the three elements, and obviously you see that there is a fourth element. And the fourth element is something we could not investigate in these explanted hearts, because this has to do with the size of the early repolarizing region, which we couldn't change in these explanted hearts because we were using the LAD. Therefore, we mimicked these observations in computer simulations. We reproduced the results I've just shown you, but on top of that, we had the additional freedom to change the region of early repolarization to make it smaller or bigger. And that's what we did here. And what you see here is that the vulnerability to arrhythmia, so the ease with which we can induce reentry, increases if we make this early repolarizing region bigger. So that's the fourth element of this circle. We need also a relatively large early repolarizing region. If it's too small, reentry is less likely to occur. Obviously, we wanted to know whether this is actually the case in patients. So we then went to our patient study in Maastricht, where we performed non-invasive mapping with electrocardiographic imaging. You can see a control individual here with a repolarization map that is pretty homogeneous. There's little difference between their early and late repolarizing regions. And in this survivor of idiopathic VF, we see a much more pronounced difference between early and late repolarization, with a steep repolarization gradient in between. On top of that, this individual did not just have steep repolarization gradients, they also had a lot of premature beats that came from the early repolarizing region, just as we saw in our experiments. And this early repolarizing region was also relatively big. We studied this in more than one individual, of course, and we confirmed all these findings. So the timing of this premature beat is critical. We know that already from the clinical ECG and other studies, the earlier the premature beat, the more likely it is to induce reentry. But then with ECGI, with the non-invasive mapping, we could add on that it only is happening when the premature beat comes from the early repolarizing region. And this indeed happens to be a much more common source in idiopathic VF survivors than in other individuals. Idiopathic VF survivors also had much steeper repolarization time gradients. And we saw that they had relatively large early repolarizing regions. And we compared this between different groups. We also looked at the co-occurrence of these characteristics. So how often do we see these characteristics occur in the same individual? And here you see that these factors frequently coexist in idiopathic VF survivors. In the control group, there's only one patient that has two of these characteristics co-occurring. In the group of PVC individuals, which are individuals who had a lot of premature beats but no sudden cardiac arrest or other serious arrhythmias, there's no overlap of all three either. But in the idiopathic VF group, these ECGI characteristics co-occur much more frequently than they do in the other groups. Again, highlighting the importance of these characteristics. So what we've called apparently idiopathic VF until now may be caused by dispersion of early and late repolarization that we haven't been able to detect with current clinical tools. And we've shown with our experiments and the computer simulations and clinical study that the translational understanding that comes from this is likely what I'm showing here, that there is a premature beat that is early, that blocks against a repolarization time gradient. This region of early repolarization is so big that it can travel through that region in such a time span that the late region that has recovered can be activated again and then starts this reentry circuit. These findings implicate that we may have finally an understanding of the macroscopic mechanism of idiopathic VF in at least a subgroup of individuals. It may also provide new targets of therapy, and we'll come back to that. And because we can do ECGI repeatedly, we can actually personalize therapy as well. For example, look at the effect of quinidine in these individuals or the effect of ablation therapy. And importantly, ECGI allows to study these patients without actually looking at the arrhythmias, but looking at the substrate. And we may also be able to apply it in family members. I promise you to come back to structural substrate as well. You're seeing the circle that we just described for purely electrical substrate based on repolarization abnormalities. And thinking about structural substrate, there is also a dispersion, but then in excitable versus non-excitable tissue. Fibrosis, of course, being non-excitable, and border zone potentially having an effect as well. And you could actually take these together. Looking at excitable tissue versus fibrosis may be very similar as looking at early repolarization versus late repolarization. Bringing this together then gives us what we call the circle of reentry, and we are focusing here on the dispersion of excitability as the general concept. If we talk about dispersion of excitability, it's still important to also talk about the regions of excitability versus the regions of inexcitability, just like we did for early and late repolarization and fibrosis. It's still important to talk about the timing of the trigger, but now relative to the excitability dispersion, which of course can change over time, making this a much more complex concept. And then the trigger needs, of course, to come from an excitable region. Thinking about this, combining these purely structural and purely electrical substrates into one reasoning mechanism does have the advantage that we can actually also reason about patients that may have both. As we just have heard, our traditional strict separation in electrical and structural thinking actually may not be what's happening in these individuals. And just to illustrate this quickly, I'm highlighting here a patient who had polymorphic VT and VF in our hospital. We did CT, ECGI, and magnetic resonance imaging. And when we co-localized the findings, we saw that in this individual, there was a repolarization time gradient that was overlapping with the fibrosis region in this individual. We then included that in a personalized computer simulation of this individual, and we saw that when we give a simulated premature beat, it blocks against this region of both repolarization time gradients and SCAR. And importantly, this conduction delay and block only occurred in this computer model when we did incorporate both structure and function, and not when we just included one of the two, highlighting that incorporating both may be very important for diseases where both are present. In this individual, the functional and structural substrate is just formed by repolarization time gradients and fibrosis. The trigger was formed by an early premature beat. I didn't show you that, but that is what is triggered this polymorphic VT in this individual. We could confirm with ECGI that this premature beat came from an early repolarizing region, and we saw that their early repolarizing region was relatively big, and that this individual had a substantial distribution of SCAR with some channels in between. And I think this brings us at reasoning about finding targets for therapy based on this concept. So very generally, taking away any of these elements, of course, should be sufficient to prevent a reentry from occurring. So let's think about a functional dispersion of excitability. For example, the repolarization time gradients. If we could come up with drugs that remove these gradients, that would be very helpful. Unfortunately, I'm not aware of any that would be useful in this setting currently. For structural dispersion of excitability, in other words, for fibrosis, we of course already have our strategies, as we've just seen. And what we're actually treating here is dispersion of repolarization due to delayed conduction through these channels. Early premature beats are something that we often treat already, so there's no new concepts there, I think. But an early premature beat coming from an early repolarizing region, we may need to treat more aggressively, because those are the ones that are particularly important. And one could also think about, can we actually not change the PVC, but can we change the repolarization time of that region? Can we delay the repolarization time in such a way that the PVC doesn't have this detrimental effect anymore? Again, I'm not aware of drugs that can do that, but it would be very interesting. For example, in atrial fibrillation, if the triggers are coming from pulmonary veins, delaying the repolarization time in the pulmonary veins may be sufficient to prevent AF. So if we could come up with something that achieves that, that would be amazing. And then if there are regions of early and late excitability, we can try again with a future drug to homogenize that. for excitable tissue due to scar, we actually already do this, of course. We homogenize scar just to get this effect and remove the excitable versus inexcitable regions. And I just want to say that according to the circle of reentry, removing any of these quadrants would be sufficient to prevent reentry, but obviously biology is more complex than a simple circle drawn on a screen, so addressing multiple quadrants may create a much larger safety margin that's relevant to the patient. And this is my wrapping up slide. I just wanted to show you that we've started with this triangle of Comel on the trigger substrate modulator interaction, and we've extended it now. If you look at the circle of reentry, the left is actually about the trigger, the right-hand side is about the, the left is about the substrate, the right-hand side is about the trigger, and then the top part is actually about temporal characteristics. Dispersion of excitability is a temporal characteristics of substrate, and the way it's distributed over the heart is its spatial component, and the same holds for the trigger. We've placed the modulators outside because we believe they affect any of these quadrants. So conclusion, an in-depth clinical characterization, potentially also including ECGI, is essential to capture all these four elements that are important for the trigger-substrate interaction. And this circle of reentry reasoning allows to think about the trigger-substrate interaction both in structural, functional, and combined substrates. And the co-occurrence, so the occurring at the same time of these substrates, may be a key mechanism in some individuals. With that, I would like to thank you for your attention and perhaps also point you at something that I'm excited about myself, which is a newsletter I recently started about the innovation of medical therapy with all the recent changes that we're seeing. So you may be interested in that as well. Thank you for your attention, and I'm happy to take any questions or join the discussion.
Thank you very much with these four very interesting lectures about how to deal with life-threatening arrhythmias from different points of view. And now we open the discussion for the audience. If there is any question. Angel, there is a microphone, please. It's coming.
Quería hacer una pregunta, bueno, en inglés, ¿no? Very interesting the meeting, this session, and I would like to make a comment to the presentation of Dr. Filgueiras. In 2004, we described for the first time the presence of channels in the scar, and those channels, as you know, were related to ventricular tachycardias, usually monomorphic ventricular tachycardias. And in 2011, we were the first to describe the use of MRI to identify the conduction channel in the scar. Both times, we made the same mistake, was to assume that the identification of conduction channel was based on the use of threshold, both in voltage or in signal intensity. But that is a mistake, because what defines a channel is the difference between the voltage in the channel and the voltage in the surrounding scar. And that's the same with the MRI. There is no a threshold that defines the channel. It's the difference between the signal intensity of the channel, that in this case is lower than in the scar that surround the channel. So for that, the use of cutoff or threshold is a real problem that we learned to solve. It took several years. And what we think that is needed to identify the channel is just represent the real information that you get during voltage mapping or during signal intensity mapping. No threshold is to use the data you have. The real data, no threshold, because you lose information. And at the end, what you have shown in the last picture about the threshold, the thing that you have done was to put the information with all the threshold that you can identify, that's the same that get rid of the threshold. Because what you have to identify is difference in voltage and in signal intensity, not to identify a threshold, because what defines the channel, as I said before, is not a threshold. It's the difference in voltage on signal intensity, and this difference have to have a geometric disposition that is that in some way is logical with the certain circuit. I don't know if I make clear my position in this point, but I think.
Thank you, Angel. Can I answer? Thank you, Angel. Let me kindly disagree. So I'm very much aware of your work, and I respect that very much. But what you mentioned is much more far from what we have done. So where you talk about the differences between one area and the other are plotting there, because we are selecting specific signal intensity thresholds where we incorporate such difference over the sweep that we have done on all the potential signal intensity thresholds. Of course, we don't incorporate the difference between our imaging and the heterogeneity between imaging and electrophysiology. We don't incorporate that. But where we are aiming is to have information before the procedure, only based on imaging, because what we will have later, or you will have later, is the electrical information, but that electrical information will require mapping. The problem comes from before the procedure, can we have something? Are you planning to incorporate your heterogeneity from electrical data into the imaging in real life, in real time? Is that possible? That's the question you are planning. This is what you are planning, incorporate heterogeneity from electrical recordings and imaging in real time. Is that your approach? We can discuss that later, Angel. I think this is a matter of very interesting discussion. We may not agree in everything, but I agree that incorporating, of course, all the potential heterogeneities, but I doubt that that will be specific. Or you think that the heterogeneity between electrical data and image data will match in the same region? Or what kind of approach are you trying to deal with? So let's discuss that later. I think this will kill all our discussion here. I agree on that. I fully agree.
Okay, and any other question from the audience? I have to congratulate to the presentation from Maastricht because it has been very very strong from a physiopathological point of view, no? Can you expand the data about the sizes of the early repolarization areas to have an idea if how often may be approached or targeted, for example, a scar homogenization, etc., no? How big is that area normally? And it includes epicardial, endocardial areas?
Yeah, thank you. These are very important questions, and you actually point me to the quadrant of the circle that we understand the least currently, if it's up to me. Let me first say that what we studied in patients was done with ECGI. ECGI is a very useful technique, but its resolution is not the same as actual invasive mapping. So for example, the difference between endocardium and epicardium is something that is very challenging to detect with ECGI. We don't know how important those differences are, but at least not from our study, but from other studies, we know that transmural dispersion of repolarization is an important factor as well. If you look at structural substrate, we've had, of course, a lot of MR-based studies that have tried to show that the volume of scar or the volume of border zone is an important factor as well. But none of those studies have really reached a conclusion that shows that above a certain threshold, there is a much bigger risk for re-entry. And I actually think that it's because it's not the only element, it's those 4 elements that you need. So the size of scar, and in particular the way it is distributed, it's not just volume, but also the amount of channels that are inside the scar is very important. But then on top of that, we also need to look at functional substrates that may be changing, perhaps because this patient has a transmural gradient or other gradient repolarization, because we know those are a bit different between individuals, but also perhaps scar and border zone actually do change repolarization. So to overlay those two may be very important. So I think it's we need to better understand how big these regions need to be an issue. If you just think about it functionally, a very small region of early repolarization is just too small to conduct. It, you know, if you get a premature beat starting from a very small region, it will block against everything that's laid around it. If it's bigger, it will take time to travel, and then it may reactivate other regions simply because of the time it took to travel in that region. But if it's very big, there is simply no late repolarizing region anymore. So there must be a balance between those two, and we simply do not know yet what it is. I've used computer simulations a lot to understand that better, but from a physiological point of view, we don't have a good perspective on what that balance needs to be for a re-entry to occur.
Thank you very much.
And another question, what do you think that is behind this repolarization gradient? I mean, maybe fiber orientations or autonomic influence, or what do you think that is the clue?
Yeah, so I've only been talking about macroscopic phenomena, not about the actual cause of these repolarization gradients. We're studying that. The simple answer that we have now is we don't know. We do know that we also do a lot of studies now in healthy individuals, and we actually have noticed that despite that on a 12-lead ECG, our rhythms look very similar often. If we look with ECGI, with non-invasive mapping, we see quite a bit of variability in normal repolarization patterns. So one of the things that we are thinking about is that repolarization is simply quite variable. And of course, things like fiber orientation, autonomic nervous system, trucks, those things may actually affect that in a way that we do not fully understand now. At the same reason also hospital drugs. Quinidine is a drug that we have seen good results of. We're not sure why. For some cases, it's because it removes the PVC. In other cases, it may be because it actually also may change the repolarization characteristics of an individual. We don't know yet. We're still studying that.
Thank you. We have time for the last question. Dr. Khalife.
Thank you very much. I want to follow up on the Maastricht presentation. Regarding your patient, the first case that you showed of idioventricular tachycardia, given your circle of reentry, why is it that that arrhythmia started at that moment and not at another moment?
Well, you tell me, I don't know. So this is another one of the challenging questions that we have. We are now trying to use ECGI. It's a very complex technique, right? It's a 200 electrodes, you need a CT scan, you need a lot of time, a lot of PhD students. What we're trying to do now is to use that same technology, but then look at the dynamics. Because we do believe that repolarization may not be as static as we've believed previously. So we are letting these individuals exercise. We're just recording for an hour and see what happens. And one of the things that may happen is that these repolarization gradients or these substrate characteristics are actually dynamic. Then you can imagine that at a certain point they're more dangerous than another point. But we don't have an explanation for that at this point in time.
Thank you very much. We are on time and we finished this interesting session. So thank you very much for coming to the session.